It is my proud privilege and my pleasure to introduce to you an international scholar, author, reviewer, teacher, examiner, researcher. Recently, in America, at the University of California, San Diego, the same gentleman who's going to present to you here made a fantastic presentation which was beamed live, streamed live all over America, all over the world. So you can imagine what that did to the people who listened to the talk. Introducing Dr. Raghavan Nair Suresh Kumar, who after his initial days of brilliance at Trivandrum Medical College for his undergraduate and postgraduate training, as Dr. Vijay Kumar, as an internist, as an internal medicine person, went to PGI Chandigarh to train in DM cardiology and decided that this person's services would best be rendered for children. He later went on to start the first pediatric cardiac service in the United Arab Emirates at the Mafraq Hospital, headed the pediatric cardiology service at the Frontier Lifeline and also at the Triple M Hospital in Chennai. International scholar in pediatric cardiology at the Cleveland Clinic, course director for interventional pediatric cardiology, e-teacher for the National Board, started the humanitarian drive both with Triple M and in Frontier Lifeline with the Manorama. When I first met Dr. Suresh Kumar, there was a fantastic testimony that he gave, and I always keep hoping, would somebody say that about me? Dr. Suresh Kumar, when he said, I would like to come and be a part of this team, he said, there was a period in Triple M Hospital when he headed the pediatric cardiology service, when the pediatric cardiothoracic surgeon left and he needed one. So he called his good friend, John Valier, who came every weekend, Friday, to operate on Suresh's patients. And Suresh looked after them, and both of them made a great team for about 2 years. And he said, so wherever John goes, I will go with him. Wherever I go, Dr. John will come with me. So that's a great team effort. And I think one of the fantastic things which I realized is when an internist becomes a pediatrician, there's a whole lot of new things that come, and some of that we are going to hear today. So on behalf of all of you, let us put our hands together and welcome Dr. Raghavan Nair Suresh Kumar. Thank you for accepting my invitation.
Good morning, everyone. Thank you, Dr. George Chandy, for the nice introduction. Why do we speak of adult congenital heart disease? You tend to associate congenital heart disease with children, but then they do grow up. If you look at American statistics, they've reached a point where the adults with congenital heart disease, it is generally operated congenital heart disease, far exceed the children with congenital heart disease in US. And that illustrates the volume of the problem. And as these children grow up, there are several dimensions of problems that become evident because typical adult medical and cardiac issues get superimposed on an existing congenital problem or its modified version by surgery. And how do they respond to it and who will look after them? Don't think this is an American problem. In Kerala, we have reached a point where practically every child with congenital heart disease is looked after by government so that you can confidently say that barring accidents, any child with critical congenital heart disease will receive appropriate care comparable with the best in the world in one of 6 institutions in the state, ours included. And these children with a mortality of 1 or 2% will survive. So trust me, 10 years from now, there will be an explosion of adult congenital heart disease in Kerala. It may not apply to the rest of India, where still 90% of children with congenital heart disease do not get access to care. Hence, this topic. Some time ago, when I was in Chennai, we looked at the adult congenital heart disease data from our department over a 5-year period and published it. This was the type of picture that we got. What I want to highlight is that only a fifth of the patients were operated. 4/5 of the patients were children, grown-up adults who have not been treated for their pre-existing congenital heart disease, and this was a wide variety of problems. Contrast this with British data of 1997, when Jane Somerville, one of the big names in pediatric cardiology, made the statement that 1 out of 5 adults that she sees required surgery. In fact, that is 97. Today, Western data practically do not speak about unoperated congenital heart disease. They're only speaking of operated congenital heart disease. While in my data from Chennai, which was heavily biased because it was from a leading surgical center, still 4 out of 5 adults were unoperated. This is the difference in profile of Indian versus Western patients with adult congenital heart disease. And this different profile brings in a whole lot of challenges. It could be simply medically managing a 50-year-old patient with adult congenital heart disease who's not been treated. When you do treat them, there are challenges in intervention and surgery. And who looks after them, and how do you organize the care for children or adults with congenital heart disease? These are major challenges that any unit or individual committed to this field would face. Let me start with medical management of adult congenital heart disease. That in itself would have been a topic, but I would just give you vignettes of this problem, like long-term follow-up of adult congenital heart disease, both native and operated. There would be a pregnant woman with congenital heart disease, treated or otherwise, and arrhythmias are some of them. Even simple lesions, as they grow up, you would find an ASD with adult congenital ASD in an adult. It's much less common to find a VSD in an adult because either it is too small or it is too large and they have died or they have become Eisenmenger syndrome. PDAs, we would still see some in adulthood. That brings me to the topic of Eisenmenger syndrome. There are quite a few Eisenmenger syndrome under treatment in BISC, and the oldest gentleman from Rani is 82 years old, which says something that Eisenmenger syndrome with appropriate medical treatment can live much longer. Their expected period of attrition is only in the 50s, and individuals survive way beyond it. If you look after their arrhythmias, today if you give targeted pulmonary hypertension therapy with drugs like bosentan and sildenafil and a whole lot of newly coming drugs, they survive and they have reasonable quality of life. In fact, this 82-year-old gentleman has shared with me and Dr. John his problems with wild boars in Rani. He runs after them. And to the students, I will tell you this story. When I was in Chennai, it was very common for us to receive overseas referrals. So somebody WhatsApped this message to me. This is a 16-year-old boy from Iraq who has in the echo a huge pulmonary artery. Quite often, when you deal with such referrals, it's far more productive to talk to the family directly. I do speak a bit of Arabic. So I spoke to the father and I asked for a picture from him. This was the picture that he sent to me. This is the picture that I asked for. Do any of the students recognize why we are doing this? What have we done? We have put the fingers and the toes together. So the idea is, or maybe that light is preventing that being seen. We're seeing the fingers and the toes together. Look carefully. I will not ask you what it is. You may not have seen it yet, but note that the feet, the toes are clubbed. This is clubbing of the toes while the fingers are largely spared. There is cyanosis and clubbing of the toes while it is not there or it is minimal in the fingers. You call this differential cyanosis. If there is to be differential cyanosis, a PDA must shunt right to left. So generally, this is the feature, let's say, sine qua non of Eisenmenger PDA. And the question was whether he can come to Chennai for treatment. So I generally counsel the family, please don't come, because there is nothing that we can offer other than medical treatment. The referring cardiologist was not pleased with that, and he actually went ahead and catheterized the patient. He thought looking at a picture and saying that this patient can't be operated was not the appropriate thing to do. So he catheterized the patient and sent me the CAT data. In Eisenmenger syndrome, the aortic pressures and the pulmonary artery pressures are identical. Here, aorta is 130/90, PA is 130/80. And the saturations in the ascending aorta is 92%. That is why your fingers are not cyanosed. While in the descending aorta here, it is 82%. And that is why there is cyanosis. And this is differential cyanosis. And you can clearly say, in this patient, you can't offer surgery. In the broader entity of cyanotic congenital heart disease in adults, it can be very varied. It can, of course, be Eisenmenger syndrome. But it's very important for the treating physician to recognize that there are entities where we can actually offer treatment, particularly tautology of Fallot and Fontaine operation. These are some of the things that we can do. I'll refer to this even later. Yet another medically interesting problem that we would see is syndromic congenital heart disease. In the developed world, it would be picked up in infancy. Don't be surprised if you diagnose it for the first time at the age of 50 in India in many parts. And dealing with them, Down syndrome is the best illustration of syndromic congenital heart disease. It's a very common problem in the Middle East because pregnancy is not terminated on account of diagnosing Down syndrome. They have a median life expectancy of 50 years. There are quite a few Down syndromes around us in Tiruvalla. We had looked at the surgical outcome of congenital heart disease in Down syndrome, again from Chennai, and published it a few years ago. They do well. As far as surgery is concerned, they do well. But as they grow up, many questions would come. One of them is a grown-up Down syndrome, more likely his mother asking, can he get married? You may think that the question is outrageous, but there are instances of men getting married. And when I was answering this similar question, when I was in Muscat, there was a young Omani girl, my technician who used to help me with my translation. She had listened to it. A few months ago, she sent me a clip from a Facebook post. This was the son of a Down syndrome person. The son had become a dental surgeon. So not only that the Down syndrome person married, his son became a dental surgeon and put a eulogy to his father in the Facebook. My technician was very nice to send it to me. When you speak of syndromic congenital heart disease, we also come to the broader issue of genetics in congenital heart disease. Now, you have a whole lot of newer diagnostic techniques in molecular genetics. We have better prenatal diagnosis, so we need to be familiar with genetic counseling. And certain diseases like Marfan syndrome, the molecular basis of that and the epigenetic modifications of that and how treatment would influence it is better known. To those inclined towards fundamental science, a genetic blueprint of the developing heart is emerging, and genetics is being applied to therapy. And this is best illustrated by 22q11 microdeletion in adults, something that we have begun to recognize in the last 20 years. About 8% of pathology and related problems, which we call as congenital anomalies, come as 22q11 positive. And this can have long-term impact on their behavior, including a propensity to psychiatric problems. I was interested in the genetic aspects of congenital anomalies, and I was involved in a work with the Rajiv Gandhi Center for Biotechnology for about 10 years. And the paper published by our research scholar in the Keystone Genetics Symposium in Denver had won the Best Young Investigator Award. Our results had showed, analyzing tissue resected from the RVOT, from proteomics protein expression analysis, that there is a molecular basis for the maldevelopment of RVOT and how there is maladaptation of the right ventricle to the hemodynamic stress and how it could influence clinical behavior. I mentioned this for a reason. A couple of weeks ago, we had a discussion on how to translate a research idea into publication. I think as students, you should also wonder, how do you translate an idea in your mind? We heard a wonderful idea of perspective from the student who presented her thought here this morning. Students are known for such original ideas. When you have a research idea, in the modern world, how do you translate it into quality work? In fundamental science, like in molecular genetics, if you want to work, there are excellent labs all across the country. The Rajiv Gandhi Center in Trivandrum being one in Kerala. I've been associated with some. The way forward is having a pathologist or a basic scientist working with you and a research scholar who will actually do the bench work. That is why we were able to do this work. Moving away from that, that type of information also tells us that we need genetic assessment and counseling in a number of patients, particularly when they are potential parents, when they have some other form of malformation. Those are some instances where we need a genetic assessment. As I said, if you're dealing with congenital heart disease, the mother is an important part of the discussion. Why? There could be a risk to the mother if she has a congenital heart disease, even if she is operated. There could be a risk to the fetus. There could be a risk for recurrence in the offspring. Every mother is going to ask if she has been operated for congenital heart disease, if I conceive, and what is the risk that my baby is going to have this problem? And also, in some of the cases, the fact that pregnancy would result in early parental loss to the offspring. This parents need to know. And the maternal risk could vary from heart failure to death. But I won't even ask you to look at it. This is only to say that majority of the lesions are mild or moderate in risk. Sorry for the interruption. I just wanted to say that don't be put away by the very busy slide. I only wanted to say that the majority of the lesions in pregnancy are compatible with a normal pregnancy at a mild or moderate risk, but there are some with high risk, particularly Eisenmenger syndrome. There's a 50% maternal mortality, there's 50% fetal mortality. Therefore, we recommend termination if a mother with Eisenmenger comes. We had the sad story of a patient whom we lost in the medical wards a few months ago in the medical ICU. This was a woman whom I knew very well. She was a postgraduate in literature, but her mother forced her to marry. The husband never knew of the Eisenmenger syndrome. She conceived and came to me. I recommended termination. She went ahead and delivered. She went ahead and conceived again and delivered another child, but that had practically destroyed her. She progressively worsened and died in our medical ICU. So these are the sort of things that we can avoid by appropriate counseling, provided the family listens to it. Even the fetus could have mortality rates of 6 to 24%, depending on the mother's problem. And preconception counseling is so important. And we try to tell the patients as they grow up that before you get married, it is better that we have a talk with you and the spouse. And preconception counseling can avoid the sort of tragedy that I referred to in the young lady whom I knew. Moving away from that to a common problem in adult cardiology, arrhythmias, congenital heart disease could influence and modify the arrhythmias. Why do they happen? Because it could be intrinsic to the structural malformation. There's a patient that we are scheduled to see on Saturday, Dr. John and me. This patient had transposition of great arteries. He was born in an era where the actual corrective surgery, arterial switch, it was just being introduced. So he underwent the surgery called Senning operation. Dr. John and me saw him in Chennai when something related to the Senning had given way. He needed a redo surgery. He underwent that redo surgery. He's doing well. He's 32. He's working in Technopark. He's getting married. But he's a pacemaker. He would like us to change that pacemaker before he actually gets married. So these are the sort of issues that we face when our patients are growing up. And this is one of my celebrity patients. I call him celebrity because I don't know whether any of you would have seen phocomelia. Phocomelia is where your limbs are very short. Do you know which is the drug that caused it? Thalidomide. And believe me, this gentleman's mother had actually taken thalidomide. And she delivered a child with a huge VSD and a phocomelic, but exceptionally intelligent person. He did his MCOM from Loyola in Chennai. He had his own software firm and he used to commute between Chennai and New York because he had a branch in New York. I saw him at the age of 34 or so, had been looking after since then. He did well until he eventually developed atrial flutter, but we offered electrophysiologic treatment, RF ablation for that, which restored to him. Finally, at the age of 50, he had a sudden death. This was the arrhythmia. You can see the irregular baseline. And after radiofrequency ablation, the ECG has become normal. And equally dramatic is the story of one of my college mates. She was 50 when she met me after 25 years. She was a few years junior to me in college. When we were in college, this girl had undergone a sinus venosus ASD closure, something very difficult in 1974. There were very few centers that would do in India at that time. She did very well, became a very distinguished surgeon. And one day when she was scrubbing, she had a syncope and she needed a cardioversion. She was found to have a ventricular tachycardia. She underwent an RF ablation for that in a center, but a month later, she again had syncope requiring cardioversion. So this was something dramatic and something very troubling. So I was asked whether we can offer anything. This is a representative ECG, not hers. This is what we would call an RVOT tachycardia, white QRS complex tachycardia, LBBB morphology, inferior axis. It gives you the clue that this is arising from RVOT. Why would an otherwise healthy 50-year-old lady develop RVOT tachycardia? A transesophageal echo showed that the sinus venosus ASD patch had partially dehisced and there was a pulmonary vein which was draining anomalously. So the treatment that we offered was to actually redo RF ablation to the RVOT and redo surgery on the same day. And she did very well. The same, another simple thing, a 24-year-old woman seen for the first time in pregnancy with congenital complete heart block. Elsewhere in the world, this would have been diagnosed in the newborn period, but she actually was seen for the first time in pregnancy. But this is compatible with normal pregnancy. Only thing is, after delivery, we did a permanent pacemaker in her. I was only referring to medical problems, but there are times when we can do something definitive for them. And as a cardiologist, I would look at the interventional challenges first. What complicates the interventional scenario is the wide variety of clinical presentation, comorbid conditions, lesion-specific issues in adults, and to the regular adult cardiologist, the pathology is very novel. ASD is a simple lesion. There are huge lots of issues that will come if you're dealing with an ASD in an adult. And in my last 3 years in BIHC, I've done more ASDs above the age of 60 than I have done in the preceding 37 years together. This is something unique to us. ASDs are compatible with normal survival. So they go through life and they realize that there is not much problem until atrial fibrillation hits them when they are 40 years or 50 years of age. This can be avoided by timely treatment. A small percentage will also develop pulmonary hypertension. But when we do see them, this patient whom we had seen in Muscat, 65-year-old male, hypertension, diabetes, and dyslipidemia, all that you could expect in a 65-year-old male, he came with atrial fibrillation. And so we had to do a cardiac cath. We did a coronary angio and a TE. He had, as the angio would show, a chronic total occlusion of the mid-LAD, which could be left alone. But we closed the ASD and put a device in the LA appendage because he was a nomadic Arab who will not take anticoagulation. I refer to our BAHC series, which I presented in the West. 5 people, all women above the age of 60. All of them are doing well. We have, in fact, I have done 8 after this total. We do see some VSDs and some PDAs also, but that's less dramatic. I refer to syndromic congenital heart disease. I've used this picture from the net because I don't have permission to use my patient's picture. This is a 56-year-old lady, a school clerk whom I met in Chennai with left main disease. You can see that her left main is being stented, but she also had severe pulmonary stenosis, which we balloon dilated. So the sort of problems that coexist, very adult issue, left main, and very pediatric issue, pulmonary stenosis, coexist at the age of 56. Similarly, just like pulmonary valve, the aortic valve could also be occluded, and giving a balloon aortic valvotomy, in an adult, the balloon will not stay there. So we pace the right ventricle at a fast rate to bring down the blood pressure, then the balloon will stay there. Even more dramatic, this is a 70-year-old woman. She had a fistula from the left aortic sinus to the right atrium, which had been neglected. And she presented with severe congestive heart failure and atrial fibrillation. This is the CT angio, which shows the fistula, which is coming into the right atrium. And this is the fistula in the angiogram. And we close this with a PDA device. Coarctation of aorta, again a pediatric problem in the West, is not necessarily so in India. This was a 43-year-old woman. In fact, she had undergone an aortic valve replacement and still the coarctation was missed. So she came to me with severe regurgitation of the bioprosthetic aortic valve and uncontrolled hypertension. This was the severity of the coarctation that she had. And this is the aortogram. You can see how extremely thin is the coarctation site. But this could be fairly simply treated with a covered stent. This is what you are seeing. And that problem is taken care of. And 6 months later, a person who was on 5 antihypertensive medicine was just on a beta blocker. Coarctation, when you grow up, there are enough medical issues. There's nothing that they cannot get, which includes premature aortic, premature coronary artery disease, berry-aneurysm, polycystic kidney. If you have a perfectly repaired coarctation in infancy, when they grow up, 50% will still have at least essential hypertension. Another major interventional breakthrough, which has happened in the last 20 years, the ability to replace the pulmonary valve percutaneously. Because many congenital heart surgeries require a conduit in the RVOT, and all the conduits will, in 10 or 15 years, or without luck much earlier, they will get degenerate and you need to replace it. And the percutaneous pulmonary valve gives you the option of putting a valve there as a catheter procedure. Like this 15-year-old boy who was FISH positive for 22q11 deletion, who had undergone truncus repair. So he came with severe RVOT obstruction. So my former colleague and friend, Dr. Neil Wilson, addressed this in Denver by putting a pulmonary valve in this position. And the commonest indication today for a percutaneous pulmonary valve is repair tetralogy. Tetralogy repair is one of the major breakthroughs in cardiac surgery. But today we realize that repair tetralogy has an abnormal everything, abnormal anatomy, abnormal physiology, abnormal electrophysiology. So as they grow up, there are a number of problems. So repair tetralogy is a new disease. And one of the problems is progressive pulmonary regurgitation. And this can be addressed by a percutaneous pulmonary valve. This is a 15-year-old boy who is having a pulmonary valve implantation. But the surgical challenges are even more. This is my MMM data, where out of 151 surgeries, half of them are simple surgeries, but the others are like tetralogy, Fontan, AV canal, all a complex range of surgeries. In our brief experience in BIHC, we have operated on 150 congenital heart disease, 129 are children, and 21 are adults. Half of the 21 are simple lesions, but the others include some very challenging surgical propositions like Fontan or a redo truncus. And Fontan operation in adults is something which India is known for, because many single ventricles will come to us in adulthood. And we have a BIHC story there. We had this 22-year-old boy who was referred to me by one of my close friends, physician oncologist. He has a visceral heterotaxy, asplenia syndrome. He also has a single ventricle with severe AV valve regurgitation and poor ventricular function. This is his cardiac MRI. Cardiac MRI is an important imaging tool, which we hope to have in the next few years, I hope. This shows the common AV valve, which is leaking terribly. And Dr. John offered him a high-risk Fontan with AV valve repair. Of course, he went through a tough period initially, but what happened eventually, I hope you can read what is written there. It's a WhatsApp message which I received from the father last week. They have completed 1 week of surgery. This boy is back to college. He's doing very well. 1 year of surgery. Actually, they remember that 21st February was the anniversary for the surgery. Things that we forget, but it's a very life-changing thing for them. So this was sent to me on 21st February. And we documented the surgical outcome. This is what a Fontan would look like. In a Fontan, you connect the superior vena cava to the pulmonary artery and the inferior vena cava also to the pulmonary artery. The idea is not to allow venous blood to mix in the heart. When we can't change the circumstances in the heart, we palliate them by doing this surgery. So here is Dr. John's signature. He has taken this conduit, which people will either do extracardiac. He has taken it through the heart because the heart was abnormally located and connected it to the pulmonary artery. The boy, by the grace of God, is doing well. Adult tetralogy is similarly a number of instances that we would see in India. We are yet to do an adult tetralogy in BIHC, but this is how my data from Frontier Lifeline, which was recently published, they do well after surgery. And operated congenital heart disease will continue to require interventions. And re-interventions in operated congenital heart disease is a common problem. Because to be honest, if you're closing an ASD in a child, or if you're closing a PDA in a child, perhaps we can say that we have cured the child. For whatever else, we would tell them that you need a lifelong follow-up. It doesn't mean that they wouldn't have a normal life, just like our sending patient who is coming to have the pacemaker changed and then get married. There are things that we need to keep an eye on. These are some instances. This is a 36-year-old electrician. His tetralogy repair was at 10 years of age, and he had recurrent syncope. And when he was recommended an ICD implantation, he came to me for a second opinion in Chennai. And this was the common problem. His syncope was due to atrial flutter. We RF ablated that. But the point is, he had severe pulmonary regurgitation. So when we gave a pulmonary valve surgically, his problem was solved. He had seen us here last week. He's doing well. Multiple redo surgeries. This is an extreme case. Again, a boy who was very close to me. I'm using the past tense, mind you. On day 15, as a 2 kg baby, I saw him, and he had a critical aortic stenosis. This was in the pre-balloon era in the early 90s. So he underwent a surgical aortic valvotomy. At the time of the surgical aortic valvotomy, he had microregurgitation. We thought that that would disappear once the LV pressure comes down. Unfortunately, it only progressed. At the age of 3.5, he required another surgery. This father is a very wealthy person. So he wanted to go to the best place for that. Alain Carpentier is a big name in congenital heart surgery in the mitral valve repair. So they went to Paris to have the surgery by Alain Carpentier. But for their misfortune, 15 days after the surgery failed and the child had severe mitral regurgitation. So he had to have a valve replaced. I continued to see him initially in Abu Dhabi, later in Chennai. He was okay till 14 years ago, till 14 years of age. At the age of 14, his valve had become too small because this boy was growing. So in Delhi, they are basically from Delhi. In Delhi, he underwent a surgery to have a mitral plus aortic valve replacement. As his father would later say, my son has a habit of embarrassing the most renowned surgeons in the world. This child developed a dehiscence of the prosthetic valve, a paravalvular leak, and had a redo surgery. He did all right after that. I was in contact with them until he developed atrial flutter. So we offered RF ablation to atrial flutter, and that became all right. He came to Tiruvalla to seek my blessings before he joined college in UK. But unfortunately, while walking on a treadmill in the University of Leeds, he sustained a cardiac arrest and he died. What exactly happened to him, we wouldn't know because he was brought dead to the emergency there. But all our redo surgeries do not end up in negative outcomes. Many of them This is a 19-year-old boy. I saw him at birth with transposition. I did a balloon septostomy. Professor I.M. Rao, my colleague at that time, did the arterial switch operation. He did well. But 2 years later, he came with severe stenosis in the right ventricular outflow. So he needed a redo surgery. And another 4 years later, they again recurred. So he had another redo surgery. So at the age of 14, he had recurrence after 3 surgeries. At this time, this is the RVUT, like what it's being turned around to show that severe stenosis. And in the cardiac MR, this is where the severe stenosis is. He was given a percutaneous valve in UK, and with that, his problem settled. He's in college now. This problem is ours. This is a child that we have seen, and we have done a CT angiogram 2 weeks ago. This child had an arterial switch operation elsewhere, came to us because of the same problem as my other boy, severe RVUT stenosis. This now, thanks to Dr. Ashwin, we are able to get such nice pictures in CT angio. So we are going to redo the surgery here. This is a similar problem, again, a BISC story. This child I had actually seen in Madras Medical Mission, coarctation and VST surgery, but she had recoarctation with an extremely hypoplastic arch. So she had severe LV dysfunction because of this. So last year, Dr. John did a graft from the ascending to the descending aorta. This is the graft. Now the aorta looks fine, and her LV has become normal. At the age of 18, she's fine. In organizing a service for congenital heart disease, being children or adults, there are several challenges. If you look at this map, this shows the number of children born with congenital heart disease per million population. The key factor is that the highest number are in places where there is no service. And this interesting graph, the size of the bubble here is the population. The bigger the bubble, the bigger the population. Look at China and India. On the y-axis, you have the number of cardiac surgeons per population. And the lowest is in countries where there is the highest population and the highest incidence of congenital heart disease. So organizing pediatric cardiac surgery in developing countries is a big challenge. There's an article by my good friend, Dr. Suresh Rao in Bombay, where you are employing evolving methods to cater to the surgical needs of a large number of children at every moment being conscious of the cost. And we have a constant turnover of trained medical, nursing, and other paramedical personnel. And in the CTVS ICU, I don't think any of the nurses who were there when I joined are existing now. They're all in different parts of the world. Every center, cardiac center in the country, is faced with that problem. Because they are the people whom we train. They should take care of the children, but they certainly seek greener pastures in personal life. So despite improved infrastructure, surgical skills, things like logistics, affordability, late presentation, nutritional issues, staffing, and economics continue to negatively influence the overall results compared to those of developed nations. And these are Kerala figures, which I got from the government. For those of you who do not know, the government of Kerala launched this program called Hridyam, under which the treatment of any child under the age of 18 is free. And we are one of the empanel of 6. And under this program, this is not done by us, by including us by 6 centers in the country. It started in the last few months of 2017. That's why there are only 208, 930 in 2018, and 1031 in 2019. Our estimate is that there are about 1,400 children who required surgery, newly born, every year in Kerala. So near completely, we are reaching that number. A small number will obviously die before they get care. But relevant to today's discussion, these children will grow up, and they grow up into adult congenital heart disease. I must say that what Dr. George Andy was referring to, this talk I had originally delivered in a cardiology grand rounds lecture in San Francisco. The gentleman with me, cardiologist should know, is Bill Grossman, who authored our Cath Lab Bible, textbook of cardiac catheterization, an iconic figure in cardiology. who is an emeritus professor in UCSF. Thank you.